Okay, can you tell us about natural childbirth? It's through the medical field, and is it completely different entity or part of medical practice?
Well, first of all, I've been working in the medical field for over 40 years. And when I first learned typical labor and delivery philosophy and practice, I didn't like it. I didn't like what was being done to women and to babies. And so I had to go along with it because that was the education at the time. But over the years, I've come to see that even the word natural birth has been taken away from women. And when a doctor says to me, oh, I do natural births, I ask him some very critical questions. And are those natural births, first of all, in a hospital? Yes. And that's entirely possible. But then I ask, are those natural births on a bed? Yes. Are those natural births with an IV in? Yes. Are those natural births with an electronic fetal monitor attached? Yes. Are those natural births with a woman's feet up in stirrups? Yes. Do you direct her how to push and where to push and when to push? Yes. Do you immediately cut the cord? Yes. Do you take the baby and put it on a warmer? Yes. And then I say back to them, there's nothing natural about that. So natural has been co-opted for a vaginal birth. So however that happens, she can have narcotics, she can have anesthetic, an epidural, and it's still considered a natural birth. For the most part, it's usually also means a natural birth would be an unmedicated birth. And I hear doctors all the time also say, why would anyone choose to have a natural birth when they can have all of their pain taken away? So that's the current climate right now, that doctors in hospitals and some midwives also in hospitals all around the world, and I have taught in and researched in 58 countries. So I've been in many different places, including Malaysia. And I prefer to erase the word natural birth and talk about gentle birth. And we changed the playing field a little bit by talking about the principles of gentle birth. What are the principles of gentle birth? Well, we start with an understanding that the mother has a mind, that she can make her own decisions, and she has body integrity and autonomy that must be respected. And that's one of the basic principles of gentle birth. There's also the principle that the baby is a conscious participant, that what we do in birth now, and the way it's taught in medical school and midwifery school, is it's our job as the provider to get the baby out of the mother and assure the safety of both the mother and the baby. So we want a live mother and a healthy baby out of this experience. But what people tend to forget is that the baby has a motivation neurologically, physiologically, chemically to be born. The mother could be in a very relaxed state, which mothers will be if they are calm, and some of them have had the experience of hypnosis or something to give them the ability to let go and surrender to the process of the birth that's happening at that time. And the baby has a prime directive. It has the first biological imperative of every human being is to get out. From the time of conception, your brain is programmed. So this mother could be either in a deep state of relaxation or even unconscious, and the baby would be born. Secondly, the second biological imperative is to crawl to a breast. And the mother still could be unconscious or in a deep state of relaxation, greet the baby and watch it miraculously without assistance attached to a nipple. So a lot of the things that we teach mothers are basically how to cope with the hospital rules and regulations. I was a Lamaze certified teacher. I was a Kappa certified teacher. And I didn't want to teach that variety of childbirth education anymore. So my goal has been to go to the source and share the clinical implications of revised physiology. And we talked to research physiologists who discovered the hormones of labor. Even 20 years ago, 30 years ago, we didn't know about the implications of prostaglandin. We didn't know the implications of oxytocin. And even today, just today, this is October 28th, 2015, just today there was a paper released that verified what other papers have said, that there's a correlation between the use of anesthetic in epidurals and of narcotics in epidurals and the inability of babies to attach to a breast. We've known this for a long time. It's been in lots of different research papers and studies and published in many different areas of science. But for that information to funnel back to the medical students who are currently being indoctrinated into the process of caring for pregnant and birthing women, there's usually about a 10 to 20 year gap, because it's just very, very difficult to get the information out of over 1 million articles that are published every year in over 500,000 journals. So it's very difficult to take that understanding and boil it down and say, here, this is how a gentle birth practice should be. And so what I like to do is go into medical schools and challenge the current paradigm. When I was in Malaysia, I did get to go to a couple of medical schools and to the Eagle Hospital system, a private hospital. I visited the largest public hospital in Kuala Lumpur, and I worked very closely with the women who were choosing to have unassisted home births. And I spent a lot of time educating them on the complications of pregnancy and birth, and kind of drawing a line in the sand and saying, this, if everything is going in a physiologic way, great, stay home, have your baby. But if you run into pathological complications, then you must avail yourself of the available technology, because we don't want to see mothers and babies dying. And complications happen. So we get into the legal aspects of, does a woman have the right to stay home and take on the human rights for her own reproductive system and the birth of her baby? So that becomes a whole issue in and of itself. But if we go back to looking at replacing natural birth with gentle birth, but even a more basic word is undisturbed birth. And when a woman's process or a baby's process is undisturbed, then how do we support? What do we do? What do we do as providers? What do we do as nurses in the hospital? When I was in Malaysia, the medical students showed me, this is our prescription for getting a baby out. And it was 63 steps. first you do this, then you do that, then you do this, then you do that. In the list was cut episiotomy, head traction, pull the baby, manipulate the shoulders. It was everything. It was 63 steps. Anybody could take that and follow along. Oh, I have to do 1, 2, 3, 4, 5. So I would like to replace that with current understanding of physiology, endocrinology, immunology, psychoneuroimmunology, and the things that are necessary to help a mother prepare to give birth undisturbed, to let the baby out. So that's 63 steps. I'd like to replace with 63 things that we can do to support a mother neurologically, physiologically, psychologically, somatically, in her body, in her emotions, in her mind, and train every doctor and every nurse how to recognize those things in this woman, and just even how to recognize the movements of the baby through the pelvis, through the exterior of the mother, looking at her pelvis, looking at her coccyx, and encouraging positions and things that allow her total freedom of movement. So that requires a gradual but complete rethinking of medical education. It has to be gradual and complete, but what I tell medical students is often create a study. Go back, talk to your professors, create a study comparing 3 hours of undisturbed skin-to-skin time with 1 hour of undisturbed skin-to-skin time, and put your professor's name on it and make them famous. After you publish, you get all the connections, and your professor, the doctor who oversaw the study, doesn't have to do any work whatsoever, but he gets his name published and you don't. And then he becomes famous, and then he starts teaching based on his studies. So, and it works. I've done it. I've helped medical students in Mexico and in Ecuador, and things change very gradually and effectively that way. Because if somebody's famous for the study that they did on allowing first-degree tears to happen without suturing, then they start going around the country and teaching it at the same time. So there's sneaky ways to get medical practice to change as well. But the overall, just have visiting teachers and visiting experts come into your medical schools and to share the huge body of literature of what we call today evidence-based medicine.
What is the waterbirth and what is advantages? And how can waterbirth help in reducing labor pain? And can everyone practice this technique, waterbirth? And what is the most common restrictions for women who want to practice waterbirth?
The practice of waterbirth has been documented back to ancient times. It's wherever women have lived near warm water. They have availed themselves of the comfort and mobility that water provides during their birth process. It's been documented off the coast of Africa, in Samoa, with the Menehuna people in Hawaii. There's a tribe of Africans from a lost slave ship that crashed into the coast of Guatemala. They practiced waterbirth right there in the shallows. Even the Indians, the native peoples of Panama, birth in the cold water of the rivers. So it's not something new, but the first medical literature that actually talked about waterbirth was published in 1803. So 280 years ago, or where are we? 200 and I forget where. Yeah, over 200 years ago. 1803. Yeah, almost 200 years. So fast forward to modern times. And water birth was not introduced at home right away. It was actually introduced in hospitals. So it can be integrated into any hospital setting, into any birth setting, into any home birth setting. But it takes a certain understanding that it's an unmedicated opportunity. The water itself is not what takes away the pain. And I don't like to use the word pain because pain is very subjective for every single person. And what I like to connect with water is that it increases your comfort. If I say to you, "Are you comfortable?" And you say, "Yeah," I say, "Can you be more comfortable?" Yeah, maybe if I move this way a little bit, or, "Oh, that's much more comfortable. Thank you." You know, and the water is the same way. Are you comfortable on the bed? Well, maybe you'd like to get into a bath, and when you get into the bath, you're more comfortable because just the warmth of the water hitting your skin stimulates your fibers in your skin that automatically send a message to your brain that says, that feels good. I'm going to start turning off the release of catecholamines in my brain, and I'm going to start turning on the release of oxytocin and endorphins. And that endorphin, I call it the ah effect. You get into the water and you go, ah, and you instantly get a smile. And then that reinforces what your body is actually doing. It's interpreting those signals. And you suddenly relax a little bit more, your shoulders drop a little bit more, and then you get more oxytocin and more endorphins. And there's a chemical reaction in the water from being buoyant. If you're sitting in water like this, you'll get a mild reaction. If you're sitting deep enough to cover your belly, you'll get what's called buoyancy. And the buoyancy actually changes the way your brain works. And it will redirect blood flow from your extremities up to your heart and signal your brain that you have to get rid of some of that fluid, so you're going to want to pee. Who hasn't gotten into a swimming pool and 5 minutes after you're in the pool, you want to pee again? And that's the reaction to being in deep water. Well, what happens is your brain signals your kidneys, and your kidneys change in the posterior pituitary, again, of your brain, the balance between vasopressin and oxytocin. And suddenly you get a bolus, you get a huge release of oxytocin that lasts for 2 days. It lasts for 2 days, even if you only have a 20-minute bath. And it kind of peaks around an hour and a half. And I tell moms all the time, go ahead and pee in the water. It's your tub. It's your space. It's your womb. It's your exterior womb with a view. So laboring in water, anybody can labor in water. All they have to be is in labor. I take women swimming in pools in the ocean in early labor, and their labor does not slow down because, once again, it's how you're thinking. Labor happens between your ears, not your legs. The chemical effects that are released in your brain and your endocrine system are in control. Your pituitary and your hypothalamic system control this whole thing. It's like having a computer, and here's the program and here's the buttons, but we just don't know what that is for every single woman. But we know that water works because it helps turn off some signals and turn on other signals. So even if the pregnancy has some, not complications, but I call them complexities, not high risk, low risk, but complexities. So let's say she's pregnant with twins. That's a complexity. Can she get into the water and labor? Yes, absolutely. Will this particular hospital allow her to birth in the water with the complexity of twins? Probably not. But she could use the water for relief and for an additional comfort. Now, let's say that she has the complexity of a slightly elevated blood pressure. Can she use the water for labor? Yes. Can she birth in the water? Yes. Because it's just one complexity. It doesn't make it that much more complicated. So there are standards and restrictions when we look at the complexities. And once again, here's my dividing line. Normal pathology, even with some complexities, great, have your baby in the water. And I'll explain what happens to the baby in just a moment. You have pathology, not such a good candidate for birth in the water, because we want to be able to have access to the mother, to be able to have a little more control of the situation. And if she's kind of blissed out soaking in a birthing tub and a complication or an additional complexity is happening, then it's going to be a little more difficult to reach her and to assist her to do that. For me, any complexity that needs more attention is a reason to get out. And even an emergent situation where there's a postpartum hemorrhage or a dystocia of the baby, I have the mom stand up and I roll the bed. In the hospital room, I roll the bed right next to the tub. She stands up, she sits down on the bed, and you're ready to go. So it takes 3 seconds to make that happen. So yes, you can have safe practices even with some complexities and situations happening. At the time that the baby begins to crown, you can decide right then and there, how's the baby's heart rate? How's the mother's condition? Does she want a water birth? Or was that somebody's suggestion? I have women all the time that stand up and say, you know what, I don't feel comfortable pushing here. I want to get out. Great, get out. There is no such thing as a failed water birth. She can plan and she can think about it. She can use the water for comfort and mobility. But when it comes right down to it, it's her decision whether she stays in there if all the complexities taken into consideration and the baby's in a fine, steady state. So if she decides to stay in the water and doesn't get out, then a couple of things increase the ability for her to give birth without disturbance. One is the mobility, because in the water, nobody's restricting her movements. Nobody's telling her, lie on your back, put your feet up. They shouldn't be doing that. And if they are doing that, they're not conducting a water birth in the right way, because she needs complete freedom of movement, just like the woman in the hospital who's not in water needs complete freedom of movement. So the most favored position for giving birth in the water is actually leaning over the side of the tub. And so it's easy for the woman to lean over the side of the tub and to get into a position that allows her to respond to the movements of the baby through the pelvis. And there's no restrictions on her movement in the water. And because she's weightless, because of the buoyancy, nobody has to help her get into a different position. I do sometimes use a rebozo or a cloth that I can give to her that she can pull. And in installed tubs, we put hand grips in so she can pull herself up and get into different positions. So at the time that the baby is emerging, everybody's concerned that it's going to take a breath. But when you look at the physiology of the fetus, it's impossible. It's impossible to take a breath or stimulate the baby. It's going from a fluid environment. It's an aquatic mammal. It comes through the vagina, and the stimulation to take a breath is not the squeezing through the vagina. That's not what stimulates the mechanism for the respiratory centers. And the squeezing through the vagina does not get the fluids out of the lungs. So when you understand that physiology, you understand that there's also mechanisms that protect the baby from inhaling. And the most important mechanism is the fact that the fetal breathing movements of the intercostal muscles and the diaphragm are taken offline prior to labor beginning and after 4 centimeters of dilation. In the brain, it stops working. Why? Because we don't want the baby contracting and expanding its chest wall as it's moving through the vagina. So the breech baby and the water baby transition exactly the same way, because the stimulation for the breath, or for changing over from fetal breathing to newborn breathing, begins with gravity hitting the face for the first time. We live in a gravity-filled world. 2 kilos per millimeter on the skin, on the face. Now, if my hand comes out first and feels 2 millimeters or 2 kilos of weight, it's not going to stimulate my respiratory centers. If my butt comes out first or my legs come out first, it's not going to stimulate my respiratory centers. It's only when the face is exposed to gravity that we start switching over in the brain from fetal circulation to newborn circulation. And then there's a whole bunch of physical and chemical responses that happen in that process. The breech baby and the water baby look very similar in transition when the baby comes out of the water or the breech is delivered. They might be a little floppier. Their color is different. But just think what happens with the baby that is vertex and is born. The head is hanging on the perineum and should be hanging on the perineum without touching for at least till the peak of the next contraction, which could be 3 to 4 to 5 minutes. Vroom. And in that time, it's getting 2 kilos per millimeter, and it's starting to switch over from fetal circulation to newborn circulation. And because the head is out, the myometrium of the uterus has clamped down on that placenta and is pushing blood into the baby. As soon as the lungs fill up with circulation, then it starts taking the fluid out of the lung. That fluid increases the blood volume by 20%. And only then, in this sequence happens, and only then can the respiratories of the brain be stimulated for the baby to take its first breath. So, and how long does the sequence take? For a water baby, for a breech baby, or a vertex baby, it's exactly the same, but the vertex baby has literally a head start. And the breech baby and the water baby have a delay of 2 to 3 minutes. So we do APGARs on the breech baby and the water baby, and the 1 minute APGAR is always slightly less than the vertex baby. But if you look at water baby research, the 5-minute APGAR and the 10-minute APGAR of water babies is always better. And there's one other thing that helps with all of this, and that's leaving the cord intact, not touching the cord, not clamping the cord, not cutting the cord. And it's essential, absolutely essential, for the breech baby to not have its cord cut, because we have to assist with that placental transfusion, and it's essential for the water baby to not have its cord cut. The Vertex baby had the ability of the placenta to give that extra 3 minutes of blood flow to the baby, but the breech baby and the water baby have not had that switch over yet. So it's very, very important to leave that cord intact. And I do often support women in having a modified lotus birth. I let them decide when they want to cut the cord, if it's 1 day later or 12 hours later or whatever. But if they come to me and say, I want to keep the cord on, we just explain how it works. And in my experience, it usually falls off in 5 to 7 days. And during that whole time, the best benefit of lotus birth is that it cocoons the family, because nobody but the mother and father want to carry the baby and the placenta at the same time. So it puts them in bed together, it cocoons them. But I usually suggest that they do a modified version of it, unless they're absolutely set on doing a full version of the lotus birth.
And what is the modified version of lotus?
Well, a modified version of a lotus birth is allowing the couple to decide when they want to do the ceremony to cut the cord. And that can be anywhere from 3 hours to 3 days. It's their decision. When I'm at a home birth, I leave the scissors inside of a sterile 4x4 and say, I'll be back tomorrow. See, everything's good. The baby hasn't left the sanctuary. I call the chest the sanctuary. And I come back the next day and I say, when did you cut the cord? And the dad says, when the mom got up to the bathroom and I got tired of holding the baby and the placenta, and it's usually around 12 hours. So, and I've tried to research where lotus birth started and took place. And I've worked it all the way back to some tribes in India. And that there was a superstition, if you will, that the placenta was the spiritual aspect of the baby, and that the baby's indwelling spirit wouldn't come in until it was separated. And so they wanted to wait for that separation to take place naturally. And they said it would unfold like the petals of a lotus flower. And as it unfolds, the baby's spirit would begin to dwell within. And that was a southern tribe in India.
What is your opinion about home birth?
Well, I started attending home birth in 1985 after practicing for about 11 years in hospitals and clinics. And I apprenticed with an old country doctor and 2 certified nurse midwives. And the doctor taught me so much about what not to do. And in my own history, my grandmother was a midwife for 52 years. And she worked in a hospital with a doctor. It was just the 2 of them. And when a woman was in labor, somebody sent a horse cart or a car to come and get her, because my grandmother didn't drive. And all the babies were born at home, unless there was a life-threatening complication and there was a reason for hospitalization. So I grew up with dinner conversation, because our family included my grandparents. I knew how babies came out and who was having their babies before I knew how babies got in. They didn't tell me that until I was a little more mature. So home birth prior to the 1950s in the U.S. was about 97% of all babies were born at home prior to World War II. After the 1950s, the statistic reversed. And now in the US, it's 99% of all babies are born in the hospital. There are a few pockets of home birth where there's like a 5% home birth rate in the state of Oregon, and it's supported there. All of the hospitals that the midwives transport cases to accept them, and the doctors have acknowledged that this is a viable way to have a baby. But overall in the US, it's misunderstood and not supported by the medical system. And that makes it very difficult for those couples who want to have a home birth. And having been in Malaysia, I saw firsthand the difficulty, the judgment that goes against the couples that want to stay home for whatever their motivation or whatever their reason is. And that's why I was so willing and desiring to educate the doctors within the medical system so that women would have more options and more choices, including Waterbirth. And I just received an email a few months ago that Eagle Hospital has finally designed their waterbirthing suite and are going to have that available in Kuala Lumpur. So I'm very, very happy about that.
What is your messages and hope that you have for the audience that are going to watch this?
Well, I hope that medical students will challenge the paradigm and that women will educate themselves. The internet has brought us so much closer, so much easier to get the information that is necessary so that women have those choices and those options. When I started Waterbirth International, my mission statement was, Waterbirth is an available option for all women. And that's the key, available option. And how do we do that? With education, with support, both for parents and providers. So with waterbirth.org, providing information for parents and providers, and with the workshops and the books and the DVDs and things like that, my hope is that people will simply avail themselves of that information and empower themselves, both parents and providers, so that we can change the way we welcome babies into the world.